Thank you, Joyce, for this kind introduction. So my outline is simple. Presenting today major updates to the most recent WHO classification of thyroid neoplasms, as well as the newest version of the Bethesda system for thyroid cytology, and really concentrating on the new terminologies for tumor types and subtypes that were introduced, as well as some grading systems in histopathology, and then talk about some of the risks of malignancies that were refined for adults and children, and then the subcategorization of the AUS category. Classification of thyroid tumors has evolved over the years, and now it's more or less centered on histopathology and molecular profiles of tumors. So we know that the majority of well-differentiated thyroid carcinomas usually fall into one of these two categories. They're either BRAF-driven or RAS-driven. And the majority of the BRAF type thyroid tumors tend to have a papillary architecture or infiltrative growth pattern, and kind of more like the papillary thyroid carcinomas, whereas the majority of RAS-like thyroid tumors tend to be encapsulated and have a follicular pattern, as we see in follicular thyroid carcinoma. Both of these molecular profiles, however, can gain additional genetic alterations over time and potentially progress to higher grade cancers such as poorly differentiated thyroid carcinoma and anaplastic thyroid carcinoma. So the 2022 WHO classification with its new classification system is really more or less based on taking into account the cell of origin and the molecular profile of these tumors. So if we look at this classification, they have these follicular-derived neoplasms, and then C-cell-derived salivary gland carcinomas, and thyroid tumors of uncertain histogenesis, and so forth. Follicular-derived neoplasms by far represent the majority of thyroid tumors that we see in clinical practice, and they have been subgrouped into these particular prognostic risk categories. So another way of looking at them, they've been categorized according to their degree of aggressiveness. So the more aggressive they are, the more they are subgrouped toward the bottom. So we have benign tumors. We have tumors that are low-risk neoplasms, that is, they have excellent prognosis. Usually they're encapsulated, but we cannot quite call them benign. And then we have these differentiated carcinomas, and then we have high-grade carcinomas, and then eventually anaplastic or undifferentiated carcinomas. The WHO also introduced these new distinct entities that I will be speaking about shortly, including follicular nodular disease, invasive encapsulated follicular variant of papillary carcinoma, and differentiated high-grade carcinoma. Other noteworthy classification changes when we compare it to the 2017 versus the 2022 WHO classification. In the 2017 version, the NEFT-P was excluded if it was less than 1 centimeter in size or had a predominant oncocytic change, but that's no longer the case in the most recent WHO classification. Now we allow NEFT-P to be less than 1 centimeter in size, and we allow NEFT-P to have a predominant oncocytic appearance. Microcarcinomas, that is PTC, that's less than 1 centimeter, used to have its own entity, and it was considered a variant of papillary carcinoma. That's not the case anymore. It's not classified based on the size. Rather, it's classified based on the subtyping of histology, the same way we subclassify or subtype tumors that are greater than 1 centimeter. Cribriform Morial variant of PTC is no longer considered a variant of papillary carcinoma. It has its own entity, and it's called cribriform morial or thyroid carcinoma, and it's listed under tumors of uncertain histogenesis. Squamous cell carcinoma is no longer a distinct entity, but now is considered a subtype of anaplastic thyroid carcinoma. And then malignant teratoma, especially those that are associated with DICER1 mutation, are now classified as thyroblastoma. General updates about the new term classification is, as far as terminology concerned, is the term variant is no longer exist. They replaced that by the term subtype. So rather than referring to PTC variants, there are PTC subtypes, for example. And the reason for that, it allows for consistency with other WHO classifications terminologies, and also avoids the confusion that one may have with that term genetic variant that's often used in molecular pathology. Also, the term Hürthle cell is hugely discouraged, and now it's replaced by oncocytic. So we refer now to these tumors as oncocytic adenomas and oncocytic carcinomas, for example. And the reason for that is Hürthle is actually a misnomer. Karl Hürthle, back in the 1800s, originally described C cells of thyroid glands in dogs. So it had nothing to do with oncocytic cells. But the major changes, in my opinion, and these what I will be concentrating on in this presentation, is the terminologies of follicular nodular disease and what it means, invasive encapsulated follicular variant of papillary carcinoma as a distinct entity, the high-grade follicular cell-derived malignancy as a new class of tumors, and the grading of medullary thyroid carcinoma. Follicular nodular disease is a term that has been recommended in the new WHO classification, and it refers to a spectrum of changes that have similar histopathologic morphology. So here, for example, we're looking at these nodules, and they may be interpreted as follicular hyperplastic nodules or adenomatous nodules. Some of these have been referred to as colloid nodules, and some actually also may represent follicular adenomas that have more of a macrofollicular or normal follicular architecture. Studies have shown that these nodules may or may not be clonal, and so they represent, in reality, an admixture of hyperplastic and true adenomas. And the distinction among these nodules may not be possible either by histology or by FNA cytology in the clinical setting of a multinodular goiter. Furthermore, most adenomatous or hyperplastic nodules that we use to describe that we see in patients that present with DICER1, P10, or P10-like syndromes actually represent true follicular adenomas. So using the term follicular nodular disease avoids designating these lesions as hyperplastic or neoplastic. Follicular thyroid carcinoma is a rare carcinoma, and its incidence is decreasing all the time, but it approximately makes up about 5 to 10% of thyroid malignancies, and it's defined as this invasive follicular patterned neoplasm. You can see here it's forming these follicles, but they lack the nuclear features of papillary thyroid carcinoma. And the main spread for these type of tumors is by hematogenous spread, which is in contrast to what we see with papillary carcinoma, which basically spreads mostly through lymphatics. 3 subtypes have been described, or we usually subtype them into minimally invasive, encapsulated, angioinvasive, or widely invasive. Follicular variant of papillary carcinoma is the second most common variant of papillary carcinoma after classic PTC, and it's also a follicular pattern neoplasm similar to follicular carcinoma, except it does have well-defined nuclear features of papillary carcinoma. The previous WHO classification subdivided follicular variant of papillary carcinoma into infiltrative follicular papillary carcinoma and invasive encapsulated follicular variant of papillary carcinoma. However, when we look at clinical studies, we found that the infiltrative follicular variant of infiltrative follicular papillary thyroid carcinoma actually behaves similar to classic papillary thyroid carcinoma and other PTC subtypes. That is, it metastasizes mostly through the lymphatics, whereas the invasive encapsulated follicular variant of papillary carcinoma metastasizes and spreads in a similar fashion to follicular thyroid carcinoma. Furthermore, molecular studies also supported those clinical similarities in the sense that the infiltrative follicular papillary thyroid carcinoma tended to be BRAF-driven or BRAF-like tumors, similar to classic PTC and other PTC subtypes, whereas the invasive encapsulated follicular variant of papillary carcinoma tends to have a molecular profile similar to that of follicular carcinoma, and that is they tend to be RAS-like. So with the new WHO then, the invasive encapsulated follicular variant now is no longer classified as a subtype of PTC, and now it has its own distinct entity, and now it is subtyped similar to follicular carcinoma as minimally invasive, angioinvasive, or widely invasive. Why is that important? Well, studies have shown that when we subtype follicular thyroid carcinoma or invasive encapsulated follicular variant of papillary carcinoma, there are major differences in the prognosis and the clinical behavior of these tumors. Tumors that only have capsular invasion or minimally invasive really are very indolent, if you will. As you can see, there is no lymph node metastasis. There's almost 0% distant metastasis and mortality. Whereas when you look at encapsulated angioinvasive, depending on the number of vessels that are being invaded, they have significantly different behavior. And then the widely invasive carcinomas are the very aggressive subtype of follicular thyroid carcinoma. Just a side note, notice here how the only difference between diagnosing minimally invasive and NEFT-P, if you will, is the presence of the capsular invasion, yet the behavior still is very similar to NEFT-P. So one could argue, really, why isn't this also classified or grouped together with the low-risk neoplasms? That's for another discussion. High-grade follicular thyroid carcinoma is a new class of malignant tumors that was just introduced in the new WHO, and it contains the traditional poorly differentiated thyroid carcinoma that we have been diagnosing for many years, and then this newly introduced differentiated high-grade thyroid carcinoma. And by definition, differentiated high-grade thyroid carcinoma is an invasive high-grade carcinoma that's still differentiated. That is, it still retains architectural or cytologic features of papillae or follicles or even oncocytic appearance, which is different than the poorly differentiated thyroid carcinoma, which is also invasive high-grade, but it doesn't retain the papillae or the follicle or the oncocytic appearance, so it mostly presents in this kind of solid trabecular or insular kind of pattern. If we look at the way, if we just step back and look how we grade follicular cell-derived thyroid carcinomas back in 2017, it was kind of very simple. We had this kind of well-differentiated kind of thyroid carcinomas. That is, they have well-developed papillae or follicles, and there could be papillary thyroid carcinoma, follicular carcinoma, or oncocytic carcinoma, and then the poorly differentiated thyroid carcinoma that has an intermediate kind of behavior or prognosis between the well-differentiated carcinoma and between the anaplastic carcinoma, which basically has no differentiation whatsoever. It's kind of more undifferentiated anaplastic. So now with this newly introduced kind of category, now we have this differentiated high-grade thyroid carcinoma in the 2022 classification, which also has well-differentiated tumors with papillary, follicular, or oncocytic architecture. However, they have high grade. And these tumors behave similar to that of poorly differentiated thyroid carcinoma, that is halfway between well-differentiated and between anaplastic thyroid carcinoma. Studies have shown that the majority of these differentiated high-grade thyroid carcinoma are actually papillary thyroid carcinomas that has progressed to higher grades. It's also projected that many of the aggressive subtypes of papillary thyroid carcinoma, such as the tall cell or Hubner or columnar cell, will actually meet the criteria of high-grade, differentiated high-grade thyroid carcinoma and will be reclassified as such with the new WHO classification. That probably also applies to the widely invasive follicular thyroid carcinoma and follicular thyroid carcinoma that has extensive angioinvasion. Here's an example, a case that we had a few months ago. This is a 35-year-old female that presented with a 5-centimeter mass. And based on the histology, this tumor had kind of a columnar kind of configuration. But we could see here that this has areas of necrosis. So before the new WHO classification, this would have been classified as a papillary thyroid carcinoma, columnar cell type. But now, because there's necrosis here, there's also numerous mitosis that were present in this tumor, and more than 5 mitosis per 2 millimeters squared. So now this is defined as high-grade columnar cell papillary carcinoma and would be behaving the same as poorly differentiated thyroid carcinoma. This is another case, a 55-year-old female that had a 3-centimeter left thyroid mass, and it had a very well-differentiated appearance. It has this kind of follicular architecture. You could see here, again, making follicles. There was evidence of angioinvasis, so it was encapsulated and angioinvasive. But when this particular tumor had a lot of mitosis, so whereas in the past this would have been classified as encapsulated angioinvasive follicular carcinoma, now this would be classified as a high-grade follicular thyroid carcinoma. Molecular studies also support this kind of progression. As I mentioned before, development of thyroid carcinoma is a multi-step process that involves both early driver changes as well as late event changes. So as the tumor progresses to higher grade kind of cancers, additional genetic events take place. And so whereas the tumor may start as either a BRAF-like or a RAS-like kind of a carcinoma, then it can accumulate additional mutations. And so, for example, it's been shown that the combination of BRAF or RAS, either one of those with TP53 or TERT or PIK3CA and so forth, these cancers are, or these mutations are markers of poor prognosis and often associated with poorly differentiated thyroid carcinoma and anaplastic thyroid carcinoma. Also, studies are already showing that the progression seems to be whereas the invasive encapsulated follicular variant of papillary carcinoma and follicular thyroid carcinoma usually progress to the path of poorly differentiated thyroid carcinoma, whereas the PTC will progress in the path of differentiated high-grade thyroid carcinoma, and then from that, then it could progress even more to anaplastic carcinoma. Medullary thyroid carcinoma. Recently, the International Medullary Thyroid Carcinoma Grading System was introduced, and basically it's a two-tiered international grading system, and it kind of separates medullary carcinoma into low-grade and high-grade. The majority of medullary carcinomas are still low-grade, but high-grade accounts for about a quarter of the cases, and they're defined as medullary carcinoma that has necrosis, increased mitotic activity, or increased Ki-67 proliferative index. And these studies have shown that the grading of medullary thyroid carcinoma is an independent predictor of worse outcome, and since then it has been confirmed by other studies, and that is irrespective of the RET mutational status, the TNM stage, and various other clinical parameters. So here's a case, a 65-year-old female that presented with advanced local thyroid disease and mets to the central and lateral lymph nodes. Again, that meets the criteria. We did immunostains of medullary thyroid carcinoma. In the past, this would have just been diagnosed as medullary thyroid carcinoma, but here we could see there's evidence of necrosis, what we call comedo-type necrosis, and there were also increased mitosis, Ki-67, all that brown staining is highly proliferative. So this now would be diagnosed as high-grade medullary thyroid carcinoma. Now going over to the cytology aspect of things, and we have the Bethesda system, which is the 3rd edition that just came out. And if we look at the Bethesda system and its history, it's the first 2 editions, which were back in 2010 and 2017, achieved tremendous popularity and has been widely adopted all over the world. It provided a standardized cytology reporting system and terminology, and it made really the FNA diagnosis more effectively communicated to the clinicians, and there was no unambiguity about the meaning or the clinical implications of the FNA diagnosis. The Bethesda system established these 6 diagnostic categories that were associated with implied risks of malignancy or RAMS. In the most recent Bethesda system edition, there are significant changes, but they're minor. There are only few, and I'll go over the ones that I think are important. And those include nomenclature was updated to align with the 2022 WHO classification of thyroid tumors. And then some of the terminologies were unified for diagnostic, certain diagnostic categories. Now there are numerous publications on risks of malignancy. So now they published new risks of malignancies for both adults and pediatric population. And then finally, there was further subcategorization of the AUS category, or Bethesda 3. So in the past, 3 of the categories, category 1, 3, and 4, had 2 different terminologies. Now these have been unified to only 1 terminology. And then these risks of malignancies have been refined and updated, and now we also have risks of malignancies for children. And if you notice here that actually the risks of malignancies of children tend to be considerably higher than those compared to the adults. AUS, or Bethesda 3, by definition, we make that diagnosis when the cytology is not convincingly benign, yet the degree of atypia is not sufficient to put it in the category of follicular neoplasm or suspicious for malignancy. That is categories 4 or 5. We try as pathologists to avoid overdiagnosing or using this category. And typically what we recommended in the Bethesda system is for AUS to represent less than 10% of all FNA diagnoses. So the new Bethesda edition, the third edition, now introduced subcategorization of AUS, and now we have two subcategories of the AUS. We have AUS with nuclear atypia that is showing some nuclear features that kind of resemble or raises the possibility of papillary thyroid carcinoma, and then AUS other, which is atypia that does not look like papillary thyroid carcinoma. And these subcategorization is supported also by molecular studies as well as studies that showing variations in RUMs. When we look at the molecular studies, BRAF, V600E mutations are more prevalent in the AUS nuclear atypia, and again, because of the nuclear features of PTC, whereas low-risk alterations such as KRAS, PTED, and PAX8, PPARA gamma tend to be more prevalent in the AUS other. When we look at the literature overall, the overall RUM of AUS, if we don't subcategorize it, is about 22%. But AUS nuclear atypia is associated with a significantly higher RUM than AUS other. If we look at some of the studies that have been published here, you could see AUS nuclear is higher than AUS other in most studies, and it ranged from 1.2% higher to 3.5% higher. A couple of recent studies or meta-analysis where they actually evaluated a whole bunch of studies, and they found that it was ranging from 2.3 to 3.4 times the RUM associated with nuclear atypia versus AUS other. Pediatric AUS, when we subcategorize that, the difference is even more significant, and it's 8.5 times higher RUM associated with AUS nuclear versus other. If we try to put this in context, what does that really mean? Well, it's the RUMs that we're getting for the AUS nuclear atypia is significantly higher than we associate with AUS in general, and so it falls somewhere between the RUMs of category 4 and category 5, where here we're getting 45 to 48%, so somewhere in the middle here. So in conclusion, thyroid tumors are now classified based on cell of origin and the molecular profile. Many of the nomenclature updates have really no direct management implications, but there are two main changes that I believe are clinically significant, and that is the introduction of the grading systems for medullary thyroid carcinoma as well as for differentiated high-grade thyroid carcinoma, and the subcategorization of AUS because of the significantly different RUMs. These updates, I believe, will help guide personalized management decision for patients who are at different risk levels. These are some selected references, and thank you so much.
Thank you. Really enjoyed the talk. Sorry. Thanks, really enjoyed the talk. My question is specifically, since you mentioned how differentiated high-grade tumors is sort of changing the classification, I wanted to understand what your thoughts are in terms of our implications for understanding the aggressivity of things like the tall cell variants. Does this mean that things that would have been historically classified as tall cell are now already being upgraded to differentiated high grade? And are there percentage cutoffs in the same way that we have features and variants in tall cells when it comes to thinning patients as differentiated high grade versus the way they might have been classified historically?
So I don't, it's projected that many of those aggressive variants, like toll cell or hobnail or columnar cell, will in fact be reclassified as differentiated high-grade thyroid carcinoma. But that still means that there's some that will not, will still remain as an aggressive subtype of papillary carcinoma. And where it falls in the scale, I mean, these toll cell carcinomas, for example, are still very aggressive. They may not be to the degree that we identify with the poorly differentiated carcinoma, but I think, I mean, it will be kind of interesting going forward as we kind of filter out the high-grade carcinomas from the other aggressive variants to see if that will affect the toll cells and the columnar cells and that do not show high-grade features. How will that kind of, pan out? Maybe Dr. Tuttle, that would be something that he would look at, risk stratification in the future for that. But so this is definitely something that I would be interested in kind of pursuing.